them separately. So our topic today is transition care, commonly known as patient handoffs. There's a lot of misunderstanding of what the implications are of not having effective hands-off. This is when you sign off a patient to another resident or an attending signs off a patient to another attending. So over 250,000 people in the U.S. die every year because of medical errors, making it the third leading cause of death in this country behind heart disease and cancer. Communication errors are cited in 70% of these events, which are considered what they call sentinel events. A sentinel event is a preventable adverse event that results in serious injury and death. So just to give you some reference, the population of the city of Miami is about less than 500,000 people. So it's about half of the people in Miami that we bury every year because of medical errors, preventable medical errors. 43% of surgical adverse events are attributed to communication errors. Handoff error or clinical shift change is implicated in 66% of these. So a lot of these communication issues lead to actual harm to patients. What is a handoff? It's a verbal and written communication between healthcare professionals as they transition between work shifts. So basically, it's the transfer of the responsibility of one person to another. And I think this is what's kind of missing when these things occur. And I'll show you with some examples. Cross coverage is an independent predictor of potentially preventable adverse events. That means if you have more than one provider that has to sign off to another provider, that puts that patient at higher risk than if they're seen by the same provider continuously. What are modifiable factors in deficient handoffs? And so if there's background noise and anything that distracts either the presenter or the receiver of the information, a disorganized communication, you're tired at the end of the shift, you want to go home, you're not very organized, you forgot to say that this, you're waiting for this particular lab result, which would determine a particular intervention. And so the person that receives the information that does not get that. Or you give them so much information that they're lost in the information that you give them, or too little information. So you have to be, that's why it has to be organized. Not communicating high risk status. For example, this patient is at risk for this. So it's not just I'm signing this patient off to you, but we think there's a high likelihood this patient is going to have a respiratory arrest. So you should check on this patient. So those are the types of things that we need to consider when we structure these handoffs. An incomplete transition of responsibility, which means the person that either the person that gave the information or the person that received the information didn't properly assume the responsibility. It could be hierarchical barriers. So, for example, a junior resident may not want to hand off work to the senior resident because they're afraid that they're going to get bad evaluation. So they may not want to tell the senior, oh, you got to do this and that, and they forget to really give them something that's key. A mismatch of the information conveyed. So, depending on the level of seniority of the resident, where the resident may not be prepared to provide the information, differing expectations by provider type, like we said above. And this is one of the important ones, and you can see it by the cartoon on the right. Overestimates of how well the message is understood. So if you're saying a lot of stuff and the person that is receiving the information doesn't understand what you're saying, just as bad as not telling them anything. So that's why it's important for you to repeat the information, to ask them to recite it back to you again, to make sure that they understood it. So I know it sounds kind of cumbersome. That why do we have to, repeat the information? It's because, this is kind of what's going on in this cartoon on the right? If you tell a dog all kinds of instructions, they may not understand what you're saying. So unless that person can recite to you that they understood the gist of what you said, then your communication is not effective. So the emphasis really is on transition of responsibility. So that this is the issue. People may say, well, that's not my patient. I'm just kind of covering until tomorrow. That's not the case. If you transition the patient for your care, you're responsible for that patient. You can't just say, I'm just kind of like here in case there's a code. That's not why you're there. You're there to make sure that the patient has oversight and basically it is your responsibility. That patient is your responsibility. So that's something very important to know. And a lot of people don't realize that. The rate of preventable adverse events remains unacceptably high. Conventional non-standardized handoffs anticipated only 42% of overnight adverse events on surgical patients. That's a little bit less than 50%. So just because they were disorganized, they were not standardized, they were not using a specific protocol. And we're going to go through several protocols that are commonly used, but obviously each of these things can be tailored to specific situations. So there's no perfect handoff. It depends sometimes on the type of patient, on the type of setting, if it's an ER, if it's a surgical patient, if it's a medical patient, they may be different. And you'll see because of the mnemonics that I'll present a little bit later. When the ACGME implemented the duty out restrictions, and Dr. Ferrer was talking earlier about burnout and things associated with burnout, sometimes when you try to fix a problem, you cause another problem. So as a result of this implementation of duty out restrictions, the number of handoffs increased 40%. This is after 2003. And the average, there's average of 15 handovers during a 5-day hospitalization since 2011. That means if you're hospitalized in a hospital for 5 days, there are going to be 15 different handovers from one provider to another. So what's the likelihood that something will be missed, especially in a critical patient? Very high. There's also a cultural change in healthcare that emphasizes shifts. Before there was kind of assumption of responsibility. Now it's kind of, well, my shift ends at this time and I don't have to worry about it anymore. And we don't just pay a lot of attention to it. There's also increasing involvement of non-physician providers like PAs and nurses. Oh, and there may be some misunderstanding of who's really responsible. What the ACGME says about common program requirements. So programs that are accredited are required to optimize transitions of care, right? Which means safety, frequency, and structure. And then also programs are supposed to monitor effective structured handover processes. So it's not just you give the intern or the resident a mnemonic and you say, okay, you fill out this sheet and that's it. Somebody has to watch it to make sure that these things are happening, that it's happening in a place where there's HIPAA protected, right? It's not happening in a hallway where you can hear information or where there's a lot of distractions. That they're following a specific protocol, that the person that's receiving the information can recite it back and understands it, and that it contains the basic elements of an effective handoff. And we'll go through what those are. So we're supposed to be ensuring that residents are competent communicating with team members in the handoff process. So this particular lecture is a requirement. So when the ACGME comes for site visits for your programs, they're going to ask you, have you had any type of lecture or any type of training on handoffs? Because that is a requirement. Well, as you know, clinical education work periods for residents cannot exceed 24 hours. But sometimes, a lot of residents think like, well, it's 24 hours. I'm going to be violating ACGME guidelines, where there's up to 4 hours of additional time that can be used for activities related to patient care, such as providing an effective transition of care. So don't think that just because it's 24 hours, you have to leave. And if you don't leave, you're going to be in violation of something. Your priority is the patient. So if you have to spend another hour, 2, 3, 4, up to 4 hours, just transitioning the care effectively, and you might be saving somebody's life doing that. So obviously you cannot, during this 4 hours, you cannot give them more work. It's basically signing off. We're supposed to facilitate, as a sponsoring institution, the professional development of faculty members, residents, and fellows. And this is why we have this today. And we're obviously giving you CME credit for this, for the faculty also. So what are the in other fields, if you were piloting a plane, you see the pilot and the co-pilot, they're sharing specific information, right? And it's done in a very organized way, right? You can't, the pilot can say, well, I forgot to check the tires, or I forgot to check so the other industries have effective handover processes. And that's why driving by plane is safer than driving by car, because there's a strict following of these things subsequent to multiple accidents that have occurred. So we've learned from the accidents, right? So in healthcare, it seems like we don't learn from the accidents. We just let people die, and because we don't see the importance of this. So there's no consequence like a plane fell off. So somebody dies in an ICU, say, well, he was really sick, but there could have been something preventable, because maybe if there would have been a more effective handover process, that person would still be alive. So face-to-face transfer of information is important. You cannot do it on the phone. You cannot leave a message. So you can't say, okay, I'm going to text you all the information, or I'm going to send a voicemail to your phone so you can listen to it with my sign off. Why? Because you're not able to guarantee that the person that received the information understood it and was able to ask you questions about it. There should be limited interruptions in a quiet environment. It should not be in the middle of a hallway where a lot of people are walking by while you're doing 3 or 4 other things. There should be a structured format to decrease emissions, because that way you make sure you include everything. Like you would want, if you're riding on a plane, you want the pilot to go through every single one of those safety features, right? You don't want him to forget one because he wasn't going off a list. He was just going from memory. So that's why you can't go off memory. And I know it seems silly that, oh, well, you have to have the patient name and the code status, and those things seem obvious, but it's very easy to miss 1 or 2 things, and that could be a life or death consequence for your patient. There should be a written summary with a checklist, accurate, up-to-date information, specific contingency plans. What does that mean? If this happens, then this. If the oxygen saturation drops to this, then call critical care, or evaluate for potential intubation, or do an X-ray because maybe he's accumulating fluid. So there has to be a specific contingency plan, kind of like what happens between airplane pilot and co-pilot. If this happens, what do we do? Not that we're going to figure it out on the fly. Unambiguous transfer responsibility, right? The pilot knows that he's a pilot, right? There's no question that he's the pilot. Same thing. You took over responsibility. It's your plane. So now you can't say, well, it's not my patient. I'm just covering. You're the pilot. Both sender and receiving may ask questions. What does that mean? The sender of the information can say, well, did you understand everything? And the receiver also should be able to ask, well, wait a minute. It's not clear to me. What do I do again? Do I need to check do a blood gas in 5 hours, or can I wait till the morning? What happened to the CT scan that was ordered that is going to show that the patient's herniating? What happens to that? We had a situation at the very beginning when we started the Gamma Knife with Neuroscience Center with Dr. Wolf, where a friend of mine who's a banker basically had his wife was taking Coumadin because she had some type of a DVT, and she fell in the bathtub and hit her head. So I was out actually in the Keys fishing with my kids, and I get a phone call from him, and he says, she's doing okay. I'm taking her to South Miami Hospital. They're going to check her out. And so I said, okay, no problem. Just let me know if I can help with anything. A few hours transpired. He called me later that evening, and he said, well, she's at South Miami Hospital. She's been there for a few hours. They did a CAT scan. CAT scan was normal, but she's very sleepy. I can't really wake her up. And I said, wait, what do you mean? Like, how's that? Did she get any type of medication? So, well, they gave her something for the headache, which, by the way, is a contraindication to give somebody something for the headache, especially any type of opiate, when you're suspecting a potential brain injury, because then you can't tell. And so he called me then an hour later, says, you know what, I can't wake her up. So I said, well, I think we need to transfer her. And then so Dr. Wolf took her in transfer. He went to ask the neurosurgeon. He said, you know, I want to transfer my wife to another neurosurgeon. He said, why are you going to do that? You're disrupting my time. You know, I'm going to dinner with my wife tonight, and you're interrupting my dinner. He was very rude, but he finally signed her out. When she arrived at midnight, and she was already herniating. She had a severe bleed, which was not detected in the original CAT scan. She basically, when Dr. Wolf opened the brain, the blood spurted into the ceiling from the amount of pressure that was in the brain cavity at the time. She was unable to walk for several months. I mean, this is somebody who was in her 50s, and perfectly fine, and then basically had difficulty walking, can't walk up the stairs, can't drive a car. Now she walks, but I mean, her cognition is different from what it used to be. Her personality has changed. So this is basically somebody who probably would have died because they were going to follow up on a CAT scan follow up in the morning. So they would have probably found her dead had it not been an intervention. So this is the type of stuff that why it's important to convey this information. Read back to increase memory and familiarity, and basically standardize the handoff. So these are the data that we need to convey, right? Obviously, some of these things are obvious, right? What's the name of the patient, right? What's the sex, the location, the attending, the code status, diagnosis, any operations, focus of PMH, focus meds, any tubes, drains, lines, active issues, things to do. That's the main one. And what's the chain of command? Who do I call? So presently, there are more than 25 mnemonics for different types of tools for handoffs. And it's not a one-size-fits-all. The best handoff tool is created through flexible standardization, and it contains a minimum code clinical content, customization based on local needs, and specially specific content. This is the famous SBAR, and it was developed by the U.S. military. It's used mainly by surgery programs. So it's SBAR stands for sick, after surgery, admissions, follow closely, and essential run through. So it goes through every single item. So sick is, what is the relevant information on the sickest patients, summary of recent post-op patients that are vulnerable, and recent and expected admissions with treatment plans, and then patients with neurological conditions and who have deteriorated, and a complete run-through of the patient list, highlight diagnosis, history, course in the hospital, active issues, and outstanding tasks. You see a common pattern, right? IPASS, which is the one that we use most commonly in our med-surg floors, medical units, stands for illness, severity. It's a stable. Is it a watcher? That means watcher means that they could be unstable. We need to watch them, or they're unstable. Patient summary, what are the events that led to the admission? What's the course? What's the ongoing assessment? What do we plan to do? What do we have to do? What's the action plan, right? And what's the timeline and ownership? Who's supposed to do what? Am I supposed to check on this? Am I supposed to do a blood gas at 2 in.? Or am I just going to wait until the morning? Situation awareness and contingency planning. What's going on, and what do we plan? What's the plan for what might happen? If this patient has this particular situation, what do I do then? Synthesis by receiver. This means the receiver is summarizing what was heard, asks questions, and restates key actions to do items. This is super important because this is the only thing that tells you that the person that you gave the information in I understood it. This is our policy. I don't bore you with that. This is kind of the sheet that we use. And then obviously it's complete. So you check on, these boxes. This is for verbal. This is for oral. This is for written. And then this is kind of the tool that we use to figure out whether somebody's doing it properly. And so the person that is evaluating the information can then say, okay, wait a minute, you didn't do this and this and this. You need to be careful. In summary, you're transferring professional responsibility. The communication strategy should be face-to-face, prioritize time on the sickest patients, ask questions, read back to increase memory, verbal content with specific contingency plans, comprehensive updates, written content, tasks to be completed, and then standardize the format. And that's the end. And hopefully this will be useful. Any questions, comments?
Dr. Michelle, are we going to get this form, please?
Yeah, it's in the Handoff manual.
Thank you.
Yeah, just ask Marie and she can give it to you. But yeah, each program should be monitoring this.
Dr. Michelle,
yep.
I have a question. I have seen that not only when the residents sign out, but also in the practice when a primary care physician is sending a patient to a specialist, the lack of communication between the both is create more problem. Can you elaborate more on that, please?
You're saying when specialists are involved?
Yes.
Yeah, absolutely. Because what happens is you call a specialist and you think that, okay, he's going to handle X, Y, or Z. And the expectation from the specialist might be, well, I'm only called to look at GI. So I'm not really looking at the vital signs and everything else that's going on. And so it gives a false sense of security, because you say, well, I've got 3 specialists. I have an orthopedic surgeon. I have an infectious disease specialist. So everything should be covered, right? But guess what? The orthopedic surgeon is only looking to see if the patient needs an intervention. The infectious disease doctor is only looking maybe at whether they're getting the right antibiotic. But you're in charge, and that's the part that people don't understand. Just because you call a specialist, you're not transferring responsibility to a specialist. It's your responsibility. So that's why it's super important to to make sure that there's effective communication and it's clear what you're expecting from each consultation. So sometimes I would say there's probably a direct correlation between number of consultants and negative outcomes, because the more people you have involved, the more reliance there is between the professionals. So it's more likely something is going to get dropped.
Thank you.
Pleasure.
Is there any other questions?
I just want to say thank you, Dr. Michelle. I agree with so many people online. This was extremely practical and useful, and I think it's a good reminder for all of us to really monitor and make sure it happens. I did have a question, though, really piggybacking on Dr. Ahmed, his comment. When you do transfer to the specialist, so if I heard you right, it's the specialist's responsibility to take over the care of that patient beyond the scope of his area of expertise, or just within the area of his expertise?
Well, you will see different specialists have different interpretations of that. But I think the best interpretation is that you're only asking them to look at their area of expertise. That's what your assumptions should be. Because I have seen many a time that people consult a specialist believing that now they have a partner in the care of the patient, and that partner is looking at the overall patient. It turns out, I'd say 90% of the time, that's not the case. The specialist just wants to see, you called GI because the liver function enzymes were elevated. That's what I'm here to do. I'm not monitoring the oxygen saturation, and I'm not going to tell you anything about whether this patient needs to be intubated or not, because that's not my field. But you might have a false sense of security thinking, oh, well, I got a lot of people in this case, right? Nothing could possibly happen. Well, you're still responsible. You could even call pulmonary critical care. That doesn't mean that you don't have the overall management of the patient and responsibility of the patient. There has to be one pilot in the plane, right? You cannot have 2 pilots. Why can't you have 2 pilots? Because somebody has to lead, right? So that's why you only have 1 pilot and a co-pilot. The co-pilot cannot override the pilot unless the pilot is disabled. So they have a whole process, right? We don't have that in medicine. So the purpose of today is mainly transferring information to a similar specialty colleague, basically somebody that will taking over the case. But the specialist thing, I've seen it happen. I've seen very thorough specialists that come in and say, you know what, you're not monitoring the sugar, even though I'm an orthopedic surgeon, but I'm noticing that this patient is going to DKA. What's going on? But a lot of specialists won't do that because they're just looking at their specialty.
Do we have time? Oh. Yeah. Dr. Michel, thank you for the talk. So I think this topic is about transferring care as well as the responsibility, right? So there are two implications. One is the patient care, and the second one is the provider. Provider, because when something goes wrong, somebody is responsible for that. You know, when it goes to legal, you know, we unfortunately, that's a big part of our practice, you know, like life, that we think about the legal implication. So even though, say you call like 2 or 3 specialists, even though they only look at their own like narrow subject, like, you know, but if something goes wrong, everybody gets involved. Everyone, right? Everyone get involved. How, you know, can you shed some lights on that? You know, because of that legal implication, how should we handle, even though I'm a specialist, for example, you know, but I have responsibility beyond my specialty, you know, because to save myself, you know, from these legal problems. So I would like you to make like, you know, quick comment on that. Thank you.
Yeah, I mean, we live in a litigious society, right? So, and I think that's responsible for more issues than not, because what happens when you call a specialist? The specialist feels obligated to do something, right? Because why are you calling GI, right? Or why are you calling nephrology? So the person feel. I mean, we used to have a situation where people were calling GI on a patient with renal failure, anemia. So the gastroenterologist would say, well, you called me, right? Why did you call gastroenterology? Well, you probably shouldn't have. If the patient is not bleeding, not actively bleeding, why are you even calling gastroenterology? Once you call gastroenterology, well, guess what the problem with gastroenterology is? Is this really an iron deficiency anemia? Or is it really chronic renal failure anemia? And how do I know it's not both? And if it is both, and this person has a tumor in the colon, and I don't do a procedure to figure that out, am I going to get sued? Because this patient is going to come back 2 years from now and say, well, sorry about my dog. I had a gastroenterologist see me in the hospital, and he never said I had a tumor. He actually said I was fine. There was nothing wrong with me. So that's why I think we need to be careful. And I remember there was a time when people were calling GI for these types of things, and it would cause a delay in the patient care. Because why? The GI would say, I want to do an endoscopy and a colonoscopy, because even though this is most likely to be chronic renal failure anemia, I need to make sure that I'm not going to get sued. It had nothing to do with the care of the patient, nothing. It was mainly protecting the specialist. And so, but that's why you need to be a good pilot and be careful, you know, who you select to be a specialist and who do you call. And there has to be a rationale. What do you expect them to do? I remember I used to have a mentor in medical school that always questioned, you know, why we order certain things. And for example, you know, people would say, I want to order a CAT scan. And I said, well, okay, she's 100 years old. There's something in the x-ray. We don't know what it is. What are you going to do with the result? And they would say, well, a biopsy. Well, would you really do a biopsy on a 100-year-old that has a potential nodule? I mean, think about that. And have you asked her what you'd want to do? Because maybe she doesn't want anything done. Or maybe she doesn't want to have a biopsy and end up with a pneumothorax and a complication when maybe this is benign. Or if it's not benign, she's 100 years old. And she may not want to be, might not want to have an intervention. So basically what he was saying is talk to your patient and see what your patient wants before you start ordering tests, and assuming that you're going to do something with that information. But yeah, thank you.
Yeah, I have one comment, not really question. pilot and co-pilot. So as my own patients, I always think that I'm the pilot. All the specialist is my co-pilot to direct me right. And one of the case that I will always remember, this patient came, Mobich 2:1 block. Immediately I contact with the cardiologist, and the cardiologist did see that, but maybe the patient have other symptoms of coronary artery disease. So he did coronary cardiac cath and did the stent, and then the patient came to my office and said, I have the same symptoms. Then I called the cardiologist, I'm going to send you back because this patient needs pacemaker, not coronary cleaning. Don't clean anymore, artery is fine, So that was as a pilot to do the co-pilot. Many times that happens. Okay, so it's not disrespect, it is just communication.
Absolutely.
And I think I just want to make sure it's very clear to program directors and residents on the training today that when they refer to the specialist, that they need to understand that it's their responsibility to get the results and review them and take back control of that patient. That once you turn them over to the specialist, your role is not done. And I like the analogy of, we all think of as a pilot, as a co-pilot. So our specialist referrals are co-pilots, and it keeps the resident and the program director and the faculty at the hospital as pilots.
Absolutely. And I
A
hear it all the
limited
time.
number of knowledge.
I hear it all the time. Sometimes, you have people upset because they say, well, the specialist signed off. So what does that mean that he signed off? The patient is still in the hospital. Well, the co-pilot has certain things to do, right? And he thinks he did everything he can do as far as the specialty is concerned. That doesn't mean that the patient can be discharged. That's your decision whether the patient is stable and what else the patient needs. So there's a lot of misunderstanding. Like, people get upset when specialists sign off. Why are you signing off? Well, because I'm an orthopedic surgeon and you asked me to look at the knee. There's nothing wrong with the knee. What do you want me to do? Stay on the case and monitor the oxygen? I mean, that's not what I do. So it's important to have communication. Thank you. Who's next, Sujan?
Okay, so thank you very much, Dr. Michelle. And I will begin to let you understand and know a little bit about